Dr. Salerno.
Hi, hi everyone. Thanks for coming. Yeah, I'm Rich Salerno. I'm the clinical medical director here at Pediatric St. Vincent's Critical Care, and yeah, my topic is sepsis, and I have a very simple approach in terms of management of all kinds of critical illnesses, which is if you understand what you're doing, you don't really have to remember anything. I believe that served me well. The other thing you should know about me is that I am a frustrated physiologist. And the way I tend to understand things is through some physiologic processes. And so I am in the spirit of full disclosure, gonna go through some physiology, and yes, I am even going to show you some math. It's going to be complicated math, but it will hopefully illustrate the concepts. And I don't care if you remember the math, but if it helps you on some level understand the concepts, then then I think it'll prove its point. There'll be no calculations. There'll be no quiz at the end. So just let the physiology flow over you, and then I will make it, I hope, very clinically relevant. So here we go, I think. Okay, so we all know that sepsis is a very important and devastating disease in children, with mortality ranging from 4 to as high as 50%, depending on severity of illness, risk factors, underlying, medical issues, and geographic location. Most kids who die of sepsis die from refractory shock and or multiple organ dysfunction syndrome. And many deaths occur within the initial 48 to 72 hours. So early identification and appropriate resuscitation is critical to optimizing outcomes. Back in the 70s and 80s, an accepted mortality for pediatric sepsis was in the range of 40%. And then some very good studies came out of DC Children's that showed that aggressive fluid management decreased mortality from 40% to about 10%. So, and that had to be very early fluid management. So that gives you an idea of how far we've really come with our resuscitation knowledge. An accepted mortality in pediatric sepsis is generally considered to be about 7 to 8% right now, hopefully continuing to get better. So these are recommendations from the 2020 update of the Critical Care Sepsis Guidelines. The Society of Critical Care Sepsis Guidelines came out over the summer. So you will see a lot of waffling, you'll see a lot of hedging, but that is just the state of knowledge that we have at this point. So in kids who present acutely unwell, they suggest implementing systematic screening for timely recognition of shock and sepsis-related organ dysfunction. They also recommend a protocol or guideline, and this is institutional dependent. I believe that most hospitals, or all hospitals, should have a screening tube and a protocol for treating sepsis. And they recommend obtaining blood cultures before initiating antibiotics, as long as it doesn't delay antibiotic administration, which of course is problematic in a septic child where access is often an issue. So this is just an example. I'm not going to go through this, This is just an example of a septic shock trigger and identification tool. And you can see this, it's your typical flow diagram, risk categorization, and this is an example that from the American Academy of Pediatrics that a lot of institutions have either adopted or used as a template, but it's important for everyone to become familiar with the screening tool that you have at your facility or at your office. So let's start with a case study, and just to start going through these concepts. So you're in the emergency department or in the clinic or on the pediatric ward, wherever you will care to be, caring for a 16-year-old previously well patient that you admitted earlier for shock and hypotension. Following aggressive resuscitation with isotonic crystalloid, intubation, mechanical ventilation, and placement of a central venous line, you place her on an epinephrine infusion with subsequent improvement in her blood pressure, perfusion, and lactate, and urine output. Her ABG shows a pH of 7.38, PCO2 of 45, and a PaO2 of 95 with SATs of 100%. While you're congratulating yourself on a successful resuscitation, you wonder, drum roll please, what is the secret of life? So, what is the secret of life? What can we as organisms live the shortest time without? And of course, the answer to that is oxygen. And not only oxygen getting into the lungs, but oxygen being delivered to the tissues. So oxygen has to get in to the lungs. It has to cross the alveolar capillary membrane. It has to get attached to the hemoglobin, and then it needs to circulate to where it's needed. So here comes the math. How do we describe the delivery of oxygen mathematically speaking? Well, I'm gonna take you guys all the way back to school, but these will be helpful, I believe. So delivery of oxygen is defined as cardiac output multiplied by the arterial carrying capacity of oxygen. So cardiac output, as I know all of you remember, is heart rate times stroke volume. And then the arterial carrying capacity of oxygen is a formula you may or may not have seen before, but there it is, 1.34 times hemoglobin times saturations plus a very small factor on the right, which we'll talk about in a minute. So if we just do some simple substitution, we get this kind of ugly looking formula, but we're gonna simplify it. Let's look at this small factor on the right, 0.003 times PaO2. A normal PaO2 is 100, so multiply that by 0.003 is a very small number. That represents dissolved oxygen, which is generally not very physiologically important. So we can ignore that. Heart rate. So let's just start on the left and go through and break these things down to illustrate the concepts. So heart rate is simple. We do not purposely manipulate heart rate to increase cardiac output unless you're bradycardic. So yes, we make people tachycardic with our various interventions, such as epinephrine, for example, but that is not the intent. So we do not manipulate heart rate intentionally. So we can just take that is what it is. So stroke volume, again, going back to school, stroke volume is dependent on three factors: preload, which is volume; contractility, which is your Starling curve. The better the stretch, the better the squeeze. and you can manipulate contractility using ionotropes, and then afterload, which is you manipulate with vasoactive agents. Notice I say vasoactive agents and not vasopressors, because sometimes you want to increase afterload and sometimes you want to decrease afterload. So that becomes important. So stroke volume is dependent on preload, contractility, and afterload. Then moving across, 1.34, that's a constant. Sorry, you don't get to manipulate that. Hemoglobin, easy to manipulate. Generally, we don't want it lower. Generally, we want it higher. So the only way to manipulate that is through a blood transfusion. And then saturations. So physiologically speaking, there are only 5 causes of hypoxemia. And there they are. And really, in Oregon, unless you're on the top of Mount Hood, there's really only 4. We don't generally deal with low partial pressure of atmospheric oxygen, which is altitude. So there's really only 4. Hypoventilation, which is a high PCO2 on a blood gas. Ventilation perfusion mismatch, which is what it is most of the time. Things like examples of that, pneumonia, asthma, bronchiolitis, all fall under VQ mismatch. Extrapulmonary shunt, which is generally a right to left shunt at the level of the heart, although it can be other places in rare circumstances. And impaired diffusion, kids with chronic lung disease, as an example, can have impaired diffusion. That is, in pediatrics, that is not generally an acute process. You'll suspect that based on history. Same with a cardiac lesion, generally, except in the newborn, it's known. So generally, you're dealing with VQ mismatch or hypoventilation. That's it. So whenever you're dealing with delivery of oxygen, which is what you are trying to optimize in the treatment of sepsis, or by further extension, any shock state. And I play a game with the students where we play Stump the Formula, where they give me any classical shock state, and I show them that this formula will tell them what the problem is and therefore what to do about it. So in any shock state, for purposes of today, specifically sepsis, this is all you can manipulate. This is all you can deal with. So now you've done half of your PICU fellowship, because as I sometimes say, my job is to keep air going in and out and blood going round and round. And this is how we do it, very simply. So all of that physiology and math, and hopefully you're still awake through all of that, is all well and good, but how do we make this knowledge practical? Well, the 2017 critical care sepsis guidelines broke it down into a very nice flow diagram, which I still use. There have been some minor modifications in the 2020 update, but for the most part, this is a good way to look at how we're the stepwise approach to septic shock. So I'm not going to go through this on this slide, but we're going to break it down and go through it step by step. So recognition, key, probably the most important step in any of this is recognition. You can't treat what you don't see. So 0 to 5 minutes. Recognize decreased mental status and perfusion, begin oxygen, get access. Access, 5 minutes. Septic baby, it's a problem. Yes, you may have a crack peripheral IV starter um, working with you, or you may be one. And if you can get that IV, more power to you. But that is often the exception, not the rule, especially given the 5-minute, ideal time frame. So really think about it going IO early. It is the bone marrow is simply a non-compressible vascular space. The only pain fibers are in the skin and the periosteum. Once you're through that, there's no more sensation of pain. If it's something less than true septic shock, and you have a minute or two, you can numb the skin and the periosteum with lidocaine. So there's really IO should be one of your first things. We did a mock code yesterday, and part of the mock code was a scavenger hunt for the IO. And there was some disagreement among experienced nurses about where the IO was kept in our unit. So that was a great example. So know where your IOs are in your unit and think about it early. Again, your shock trigger tool, just throwing this back up here. This is about where you'd be applying whatever tool your institution has. And then here we go, 5 to 15 minutes, next step. So you've recognized shock, you've started oxygen, you've gotten your access. This is where the intervention starts. So if no hepatomegaly rails, crackles, then you start with 20 cc per kilo isotonic saline boluses and reassess. And we'll talk about the reassessment in a minute. Up to 60 cc's per kilo until improved perfusion. Stop for rails, crackles, or hepatomegaly. You correct for low sugar. Children are the same as adults. For people who treat both, a kid comes in with any kind of altered mental status, one of the first things to do is always check a blood glucose, same as in adults. Look, hypocalcemia, in an ideal circumstance, when you got your IV, you'd have been able to send some screening labs, and you're beginning and gotten your blood culture, and you're beginning antibiotics. So back to the secret of life. What are we doing here? We're dealing with preload. This is the shock state. Most likely the quickest, most effective, again, alluding back to the DC children's studies back in the 80s and 90s, you're intervening with volume, preload. You're loading the system, as long as you're mindful not to overload the system. So this is where the 2020 recommendations got modified, and how much fluid you give depends on your resources. So if you have intensive care immediately available, you give the 40 to 60 cc's per kilo total over the first hour, and you're titrating to clinical markers unless fluid overload symptoms develop. If you don't have intensive care and they're not hypotensive, then you don't need fluid, you don't need bolus fluids, and you just can start maintenance fluids. If you are in a system with no intensive care and you have hypertension, they recommend you be a little bit more judicious with fluids and just push them up to about 40 per kilo, and start some maintenance fluids. So how should fluids be given? This is a big question, especially if you're dealing with an IO, which generally I would recommend in cases of true septic shock with hypotension. You have basically three choices. You have a pressure bag, you have your regular IV pump, and you have your fingers in a syringe. One of them is vastly superior to the other two. So let's go through this. So pressure bag. Well, okay, pressure bag. The fluids will go in quickly if everything is working, but how fast will they go in? You don't know. Who's watching in a true resuscitation event or in any resuscitation event when everyone is busy, everyone is running around? Who is watching the drip chamber? Nobody. If you're using an IO and you got a pressure bag pushing in, who is watching the IO site? Who is feeling the kid's calf to see if the IO is infiltrated? Generally, nobody. So in a perfect world where you're sure everything is working fine, pressure bag is an option, but it has significant disadvantages. So I don't recommend a pressure bag. A pump. Well, a pump is a little smarter than a pressure bag because it's got an alarm. But again, in a resuscitation situation, probably no one is watching the pump. Additionally, the pump, as you know, the pump's maximum rate is 999. That is 17 cc's per minute. That is simply not fast enough if you're dealing with a child in septic shock with hypotension. It's just not fast enough. And again, nobody is generally watching the IO. No one is generally watching the calf. The pump is running. It may alarm at some time, but it's not optimal. Now, let's talk about fingers and a syringe. Well, your fingers are attached to your brain. Your fingers are smart. A syringe, you fill the syringe, you know exactly how much you've given, you know exactly how fast you're giving it. When I administer fluids through an IO specifically, I have my one hand on the syringe, the other hand on the child's calf, and I'm doing them both at the same time. It's continuous monitoring. If you feel a change in resistance, then you immediately look and see, is it a kink tube? Is the IO out? Is it infiltrating? So it's the fastest, it's the most accurate, and it's the smartest way to give bolus fluids in a shock situation. So the clear answer here is boluses are given with your fingers and a syringe. Now, we in that first step, we talked about, monitoring for crackles, hepatomegaly, and it's the look, listen, and feel approach. So before you give your first bolus, you look for JVD, you listen for crackles and gallops, and you feel for hepatomegaly. Then you give your bolus, and you look, listen, and feel again. You give your third bolus if needed. You look, listen, and feel again. If you detect any of those, you have to stop. That is enough fluids, because in pediatric septic shock, up to 60% of children will have acute cardiac dysfunction. Not from bad coronaries, not from cardiomyopathy, from a variety of things that are not entirely clear, but up to 60% of kids in septic shock will have acute cardiac dysfunction. So monitoring for signs of fluid overload in the setting of a poorly contractile heart is essential, unless you're going to keep from getting yourself more problems. So not everybody, not every child needs all 60 cc's per kilo. You need to constantly reassess. And so when do you, other than signs of fluid overload, which we just talked about, when do you know you've given enough fluids? What are your signs that the fluid resuscitation has been adequate? So It's simply the 5 endpoints of resuscitation, otherwise known in my world as the normals. Normal heart rate, normal perfusion, normal blood pressure, again for the situation, normal mental status, which may just mean that the child is starting to wake up, starting to cry a little bit, and normal or establishment of urine output. Those are your endpoints of resuscitation. Very simple bedside things that you look at. Kind of coming into the for the last 3 years, well, we've been talking about it for a long time, is lactate. Lactate is a sign of anaerobic metabolism secondary to, again, back to the formula, inadequate oxygen delivery. So in the 2020 iteration, they were unable to issue a recommendation about using lactate levels to stratify children. However, on a practical clinical level, an improving lactate is absolutely a good sign. So in your initial screening labs, I would absolutely recommend getting a lactate. And then if you're reaching the point where you believe your fluid resuscitation has been successful, following lactates to help guide you is definitely helpful. So perhaps you're in the unfortunate position where you've given your IV fluids, you've given your 60 per kilo, look with your fingers and a syringe, you've looked, listened, and felt before and after every fluid bolus, and you've assessed them for reestablishment of the normals, the 5 endpoints of resuscitation, and you're still not where you want to be. Where do we go from here? Well, back to the formula. So you've done due diligence with the preload, and by virtue of the preload, you've also addressed your starling as best as you can. So you've given the stretch for the maximum squeeze. So this is where you start to think that contractility may be the issue, and you're reaching for your ionotropes. So 60 cc's per kilo is the definition, the research definition of fluid refractory shock, and so you're beginning your ionotropic therapy to improve contractility. The recommendation in 2017 and the current recommendation is generally to start with epinephrine. If you, at this point, you're thinking about a central line, you're thinking about airway access, use of, you can use ketamine and atropine because they are so hemodynamically friendly. For those of you in the ED, remember that because of adrenal suppression, in any case of suspected pediatric sepsis, that etomidate is contraindicated. So atropine, ketamine is the recommendation for sedation for any kind of central venous access attempt and for intubation. So you're going to titrate. You're going to titrate your epinephrine for cold shock. I generally, even though the range is 0.05 to 0.3 initial range, I generally don't start on the lower end. I will start at 0.1 or 0.15. If you start that and they get tachycardic and their blood pressure, and you overshoot the blood pressure, my feeling is that that's a nice problem to have, and you can back off. But if you're, titrating up slowly, you're leaving the child hypotensive potentially. And a little factoid to remember is that for every hour a child is hypotensive, their risk of mortality doubles. So treating hypotension is essential. So epinephrine, the recommendation here is epinephrine for cold shock. nor epinephrine for warm shock. The 2020 iteration is a bit more nuanced than the 2017. So warm shock is generally considered to be a vascular failure, a failure of afterload, a decreased afterload. Current data suggests that that may not be completely accurate, that a lot of kids who appear to have warm shock or vascular failure, afterload failure, also have a contractility failure. So clinical signs alone may not be adequate, and they make the suggestion of using various things, an A-line, Doppler, cardiac ultrasound. All of those things are generally not immediately available, but one thing that is immediately available, especially if you have central access or even if you don't, is the venous saturation, which is another measure of, again, delivery of oxygen. So that is readily available. If you do not have a central line, any venous saturation will get you in the ballpark. So what to do at this point? You're titrating your epi, you're titrating your norepi. So they recommend we recommend trending blood lactate levels like we discussed. And then strongly consider following venous oxygen saturation for oxygen delivery. And we'll talk about that again a little bit more. So you're titrating your fluid, you've given your fluids, you're titrating your ionotropes and your vasopressors. Remember, we are still within the first hour of the resuscitation. And you're just not getting where you want to be. And now what do? Well, this is the definition of catecholamine-resistant shock. And this is where the hand-wringing really begins, when you start to think about glucocorticoids. In my 20 years plus doing this, the pendulum has swung on glucocorticoids in sepsis all over the place. The recommendation in 2017 was, if at risk for absolute adrenal insufficiency, consider hydrocortisone. Okay, that's kind of not particularly helpful. So if you're confused, so am I. The 2020 iteration suggests against using hydrocortisone if you've gotten to where you need to be with fluid resuscitation and vasoactive therapy. Great, and that's a no-brainer. But they do the next thing, they suggest that either hydrocortisone or no hydrocortisone may be used if fluid resuscitation and vasopressor therapy are not adequate. So do what you want. I can say, as a practicing intensivist, that if you're pushing fluids, you're titrating your vasoactive therapy, and you are not getting where you need to be, it takes a very cool hand to not give a dose of hydrocortisone. That recommendation is my own and my experience. It is not a recommendation of this is the recommendation. The bottom of the slide. Random cortisol levels are your options are a random cortisol level, which can be difficult to interpret. You can do a cosentropin stim test, which under best circumstances will take you between ordering it, getting it from the pharmacy, administering it, drawing the blood, and getting the lab results back, will take you at least on the order of 3 hours. And again, Every hour a child is left in shock, their risk of mortality doubles. So that's a long road that you may not have time to do. If you've ever seen a child with adrenal insufficiency in septic shock, or say someone with Cushing's, if you give hydrocortisone and they're truly adrenal sufficient, it is almost miraculous. You're cutting back on fluids, you're cutting back on ionotropes almost as fast as you can within 30 to 45 minutes. If it doesn't work, a single dose is probably not going to be that harmful. But that is the state of the art of hydrocortisone and septic shock right now. It is not clear. It has not been clear, and I don't see it being clear in the future. Yes, if you have a child who's been on chemotherapy, including steroids, if you have a child who has asthma and has recurrent uses of prednisone, then you have higher risk, but that is not typical. So just a little bit more. So back to here. So again, I've ignored the saturations, but you are managing if the child presented with pneumonia or hypoventilation, you're managing those as best you can at this point by using the ventilator and oxygen therapy and PEEP. But we're back to this. We're addressing preload. We're working on contractility, and afterload we haven't really touched yet. So now we're still in catecholamine resistant shock. We've wrung our hands about steroids, given it or not, and now we're kind of into these three baskets. So let's just break these down a little bit more. So if you have low blood pressure, warm shock, and there's the SCVO2, central venous oxygen saturations greater than 70%. I'm going to stop and talk about that for a minute. So in health, you can assume that all of our saturations are about 100%. So our venous saturations in health, our venous saturations in our pulmonary artery are generally around 75 to 80%. This is the way I think about it. Each little hemoglobin in your red cells carries 4 oxygen molecules. So in a trip around the body, the typical hemoglobin will give up 1 oxygen. So that gets you from 100% saturated to about 75% saturated. If your oxygen delivery is inadequate, and remember, this is what we're talking about the whole time, is oxygen delivery, the secret of life, then the cells will be forced to pluck off more than their allotment of oxygen from a hemoglobin, and your central venous saturations will drop. So central venous sats are a good sign of adequacy of oxygen delivery along with lactate. So if you're low blood pressure, warm shock, your central venous saturations are greater than 70, so delivery is the problem. So delivery is not the problem, and you've done all your fluids, then this is an afterload failure. This is classic, warm shock. So this is a failure of afterload. So you're going to tighten up the afterload, and generally you will do that with things like norepinephrine or phenylephrine, the pure alpha agonists. There doesn't seem at this point to be a particular problem with contractility. The problem here is going to be afterload. Tighten it up with your alpha agonists, norepinephrine and phenylephrine. So low blood pressure, cold shock, Central venous sats are less than 70. Okay, so inadequate oxygen delivery, your lactate is most likely going to be high. And oh, we've brought in hemoglobin now, hemoglobin greater than 10. So in pediatrics, like in adults, we use a restrictive transfusion. Um, Generally, the transfusion threshold is a hemoglobin around 7. But here, you are starting to bring hemoglobin into it. So you want to start thinking about giving pack cells to get that hemoglobin around 10. So you have low blood pressure, cold shock. This this tells you that there's both cardiac and vascular failure. So you have to increase the afterload and keep working on contractility. So you're titrating your epinephrine, and at this point you're adding norepinephrine and maybe some of these other things. But the idea is that you're increasing afterload and you're increasing contractility at the same time, because you both have a contractility failure and you have an afterload failure. And then hemoglobin, again, you're bringing hemoglobin into it at this point. So you're addressing your saturations, you're addressing your hemoglobin, and you're addressing your stroke volume you've already done the preload. Now you're continuing to work on contractility and afterload. And then if you have normal blood pressure, cold shock, again, mixed venous saturation is less than 70, inadequate oxygen delivery, you're getting your hemoglobin, again, up to 10, greater than 10, you're on epinephrine. This is where you want to start thinking about things like milrinone. Milrinone is an interesting medication. It is a so-called ionodilator. So it increases contractility and decreases afterload. And the net effect is that it does not increase cardiac work. So in a child where you're still cold, but he's able to maintain a normal blood pressure, this is supporting the heart by giving it less work to do. By increasing the contractility and decreasing the afterload. And this is a great spot for milrinone. So just to throw that out there. So again, contractility, afterload, hemoglobin, you're working on your saturations, generally through your mechanical ventilation. So, conclusions, you need rapid recognition, timely interventions, and continued reassessment to successfully manage sepsis. I hope I've convinced you that an understanding of the physiologic concepts can help you with individuals, and as part of your 45-minute PICU fellowship, you've realized that you really only get to manipulate 5 variables to ensure adequate oxygen delivery, which are preload, contractility, afterload, hemoglobin, and oxygen saturations. And there are only 5 causes of hypoxia in humans. And if you're not at altitude, there's really only 4. So not as much to, if you understand those concepts, I hope that the treatment of sepsis can feel a little bit less overwhelming. So I finished I finished as early as I wanted to, and so we have lots of time for questions.
The first question we have is, our adult ED providers tend to start vasopressin. Any evidence in kids?
Vasopressin, so I'm going to slide back here. Vasopressin, there is some evidence for vasopressin, but in the And if you look at the studies of people who've looked at vasopressin levels in septic children, they're low. You have failure. Now vasopressin in children comes in rather late. It would come in, kind of on the bottom here, here or here. But it is not recommended to be a first-line treatment for pediatric septic shock.
The second question is, would you recommend checking a cortisol level before giving hydrocortisone? We had a case of adrenal shock this past year, but didn't get a level first.
I would. Now the issue is often that access is an issue, and when they're initially presenting and you're initially doing your admission labs in the first 5 minutes, probably a cortisol level is not routinely ordered, nor do I think it should be. So I would, if at all possible, have a random cortisol level. Now, so on a practical matter, if you can get it, yes, you should. It may be able to, if the lab has extra blood from the admission labs, you can get them to add it on. That's often possible. A lot of times in a true resuscitation event, you send, and you get blood, you send a rainbow of tubes, and there can be enough blood. But like I said, a random cortisol level is often difficult to interpret. If the level is 0 or 2, then you know what you're dealing with. If it's 50 or 60, you're probably okay. But my experience is that it's neither of those. It's 12 or 8 or something like that, and it's going to be very hard to interpret. So, should it be part of the, your initial rainbow? Probably not, because the vast majority of kids are going to respond to fluids, and maybe some ionotropes, but you're not often going to get down there. But it's definitely worth a thought, especially if you're not going to if you're not getting to where you want to be as quickly as you'd like.
So the follow-up question is, so for intubation, you'd recommend atropine, ketamine, and a paralytic as well, or any particular paralytic?
The atropine and ketamine is the recommendation because of the friendly hemodynamics. It's a sympathomimetic, so it's not going to make you hypotensive. Choice of paralytics. I am generally not a big succinylcholine fan. Besides, undiagnosed myopathy that most people know about, but it can raise your potassium, and in a hypotensive child who may have impaired kidney function as part of their multi-organ failure, that can be problematic. But other than that, I think any of the non-depolarizing neuromuscular blocking agents is fine. I'm not aware of any particular preference.
Okay, thank you. I don't have any other questions that have been submitted in the chat, but I do realize we have a few people that are just on the phone. So if you are just on the phone and not on the computer, please feel free to unmute. Oh, we have another question that just came in. What are your thoughts on LR versus normal saline for fluid resuscitation?
Oh boy. Okay. The old joke is your preference depends on who you were trained by. You know, pediatricians are trained by, are generally trained to favor normal saline. Anesthesiologists are generally trained to favor LR. I think the bottom line is it's not all that important. I myself will do the first 60 per kilo of fluid in saline and then switch over to LR, because at that point you're administering a lot of chloride, and it's you start to get into trouble with hyperchloremic metabolic acidosis. The bottom line is LR versus saline is a philosophical issue rather than a medical one. Any isotonic crystalloid will do. The recommendation is that you use crystalloid rather than albumin and that kind of thing because of availability and such, but LR or saline doesn't really matter.
Thank you. Any other questions from many of our session participants? Which antibiotics do you use?
The antibiotics, it's the I guess the usual. If you're over 3 months, then generally ceftriaxone. Under 3 months, whether you're doing Ampingent or Ampin, whatever the current preferred cephalosporin is, not ceftriaxone. So the usual recommendations apply. The issue generally comes up around vancomycin. If you're suspecting for whatever reason a resistant organism, vancomycin has to be run in at least over an hour, and vancomycin is not compatible with anything, pretty much. So Vanco is, it may be indicated, but you need a dedicated line. And if you're running resuscitation through an IO, you're not going to have the space for it. That may have to wait until you have a central line or a different another access point to dedicate to the vancomycin. So usual and customary antibiotics, vancomycin is kind of the wild card that generally has to wait until you have better access.
What sepsis screening tools do you use at Providence, and are they built into your EMR?
Oh, that would be a question for the ED. I honestly don't know what we use here. Embarrassingly enough, I don't know what we use here. I don't know if there's anyone from our ED who could speak to that. Come on, someone bail me out.
That's a good question. I don't know from the names who was in your ED, so.
Sorry about that.
That's okay. Any other questions? Okay, for those of you still on, we just wanted to let you know, first of all, actually, that we will have CNE and CME available for this presentation. We'll be sending you an email out after the session. Those must be submitted by the 27th of November. And then the process will begin on the 30th to get those complete and sent out to you. And then we'll also have a University of Continuous Quality Improvement workshop that's coming up in February. This will be a 2-part workshop, February 18th and 25th, and you can find more information about that on the website. I wanted to thank you again, Dr. Salerno, for presenting today. And if there are no more questions, I'm just checking again to make sure we don't have any additional questions. Let's see. Nope, no more questions. So thank you very much. And that'll be the end of our presentation today.
Thanks, everybody.